Okay, so here is a quick review of what we're going to talk about. Well, not going to talk about what you're going to do in the exam. Huh. Just noticed that for some reason it is like graying out my things that are going to be there. Like you can still see them, but they haven't. That's weird. Anyway, all the answers are given away. That's fine. You're going to get them eventually. But okay, so as usual, if you want to pause this after I ask the question before I give the answers, I think it's a good idea to quiz yourself that way. But of course, you can just watch it. It's totally up to you. However, the best way is for you. Okay, so what effect do changes in resonant cavity size and shape have on a sound? Well, that's pretty simple. They're going to make different formats, right? Different speech sounds are going to be created by these different resonant cavity sizes and shapes. So an E and an and an oo, like we've talked about, those are all created by different shapes and sizes of the resonant cavity in different areas. So the pharynx will be either larger or smaller, shorter or longer. The tongue will be in a different position for all these different formats, different speech sounds. The formats are what you see with the acoustics, stripes of energy, essentially at different harmonics. And then speech sounds is just what we perceive. How can you measure those? Well, I kind of gave that away already. Acoustics, right? So you can measure these different formats by looking at the acoustics. So you can record somebody with a microphone like this, and then you can measure their speech sounds. You can look at it, and you can look for different format bands, and that's what tells you that there are different shapes and sizes of the resonant cavity. When the naso and oropharynx are open, there is more or less resonant area. I said larger. Should be more resonant area. That answer doesn't really fit grammatically in there. But so there's more resonant area. Okay, so what happens when a sound... No, what happens to a sound when its wavelength equals the length of a tube it's played through? This is one of the first things we talked about in this section of class. Well, it resonates, right? So if the wavelength is equal to the length of a tube it's played through, it's going to resonate, which means it's going to accentuate that frequency. That's going to become a format, basically. And then what three general portions of the pharynx are there? There's the laryngopharynx, the oropharynx, and the nasopharynx. Okay. So now we're going to talk about bones. What is the lower jaw called? It's the mandible. But what is the process right here about where the jaw articulates with the temporal bone? It's the condylar process. Don't get distracted by the coronoid process down below. But what does happen at the coronoid process? Well, that is where muscles can attach. It's an attachment point for the muscles. Specifically, the two largest ones are the temporalis and the masseter, the ones that matter most in terms of chewing. And other ones can hook in there as well, but mainly temporalis and masseter, most important to know, that hook into the coronoid process. Coronoid process is slightly anterior of the condylar process, and it also looks a little bit more like a tooth. The other one's kind of like a rounded end. Okay, so how does the jaw articulate, and how does that relate to TMJ pain? Well, first of all, what does TMJ stand for? Temporomandibular joint, right? And so that's what we're talking about with the condylar process. That's the temporomandibular joint. So the jaw articulates with an articulatory disc, is what helps the condylar process move easily against the temporal bone. But sometimes that articulatory disc can slip out of where those two bones are articulating against one another, and that can cause TMJ pain. One of the other causes of TMJ pain is just tension in the muscles around the temporomandibular joint. When the articulatory disc is slipping in and out here, that's what causes jaw popping. That's one of the things that causes that. And that can either get worse or it can resolve itself. Okay, so what makes up the septum? It is the vomer, the perpendicular plate of the ethmoid bone, and the septal cartilage. Can't forget about that cartilage. How many nasal concha are there? There are 3. What are they called? It's an easy one. They're the superior, middle, and inferior nasal concha. What do they do, though? They warm, moisten, and filter air when you're breathing through your nose, specifically. And then the sinuses are in there as well. So there's sinus openings within and near the nasal concha. What are the extracranial bones called? There are 2 different names for these. There's the actual name, and then there's some name that people called them. The actual name is Wormian bones. It's named after the person who documented them. And then also sometimes they're called Incan bones because they're found a lot of times in those skulls of native South American cultures that do a lot of the head elongation. So Wormian bones or Incan bones. Okay, let's take a look at the skull really quickly. We've got the frontal bone here. Is it paired or not? I'm not even going to give you the answer to that one. You should know that. This is the parietal bone. Paired or not? You need to know that. This is the occipital bone. Is it paired or not? The temporal bone. Paired or not? The sphenoid bone. Is that paired or not? And right here is the ethmoid. Is that paired or not? Also, here's the condylar process, the coronoid process. This is the mastoid process. Man, that was about to leave my brain. Right here is the mastoid process, and here's the styloid process. Okay, excellent. Let's move on. Where do the teeth go? The answer is not into a nice, delicious burger. I mean, that is the answer, but it's not the answer for the test. The answer for the test is they go in the alveolar processes of the mandible and maxilla. What is the horizontal plate? This is a loaded question. I want you to know what the horizontal plate goes with, what part of the bone is that. So go ahead and think about that. What does it make up? What does the horizontal plate make up? That's actually it. It's not really that loaded. There's 2 parts. Okay. So it's part of the palatine bones, right? The horizontal plates are part of the palatine bones. And they create the posterior part of the hard palate. What parts of the skull does the maxilla contribute to? Well, the maxilla makes up the anterior portion of the hard palate, specifically the palatine process of the maxilla. The maxilla creates the lower portion of the nasal opening. We've got nasal bones up here, but this is maxilla down here. The orbital sockets in this region are maxilla. The alveolar process, we talked about that with the teeth, that's maxilla. So everything right, in here, this is all maxilla right here. What sutures fail to come together in most cases of cleft palate? I guess I should actually phrase it. What suture fails to come together in most cases of cleft palate? It's just one. It's the medial palatine suture. And then for cleft lip, it's also the incisive suture. So if you had cleft lip and cleft palate, it would be the median palatine suture and the incisive suture. What is the buccal dental surface. It's the outer surface of the teeth, right? So this one closer to the cheeks. Not this, because that's the labial dental surface. But this and this is the buccal dental surface. Don't get it confused with the lingual dental surface, which is on the inside of the teeth. And even though the front of the teeth is not the buccal surface, because it's the labial surface, all of the inside portions of the teeth, the inside surfaces of the teeth, are lingual surfaces because they all face in towards the tongue. Remember also, this is something that's also important, is that when you're talking about teeth, medial is towards the middle, right here, where this gap is. Ding! That's the most medial portion of my top teeth. And then distal is going to be away from that. So you kind of think about them arranged out in a line. So you take it, they're like this, the teeth, and you take them out, and then you spread them out into a line, right? So the molar all the way back here is the most distal. Even though it wraps around and it might be in line with some of the other teeth, it's the most distal because you're measuring from the center point. So you should know that. How can improper closure of jaws impact speech? I'm looking for a really generalized answer here. It's just articulatory problems, and especially dental, for dental sounds like th, t, d, stuff like that. Or some of those are alveolar ridge, sorry. But th, th, a lot of those. So if you don't have the teeth in the right place to be able to, like, you know, put two things together, a tongue and teeth, or lips and teeth, or something like that, then you're going to have problems with those sounds. But in general, articulatory problems. Okay, let's look at these pharynx muscles. What are the major muscles of pharynx closure? How do you make the pharynx smaller? There's 3 of them, and they're in these top 2 pictures right here. They are the superior, middle, and inferior constrictors. We also have 3 muscles that shorten the pharynx. They're going to pull up. One of their major functions is pulling up. They are not pictured on this slide. Sorry about that. Well, one of them is. They are the salpingopharyngeus, the stylopharyngeus, and the platopharyngeus. Remember, in general, all of these are pulling up. They're shortening the pharynx. Now, what can widen the pharynx? The stylopharyngeus can widen the pharynx. It actually does a couple different things. It reminds me a lot of the aryepiglottic muscle that has 3 different functions that it can do. So the stylopharyngeus shortens the pharynx. It's going to pull up. You can kind of see it. It comes down like it's choking this person and back up. So it's going to pull the pharynx up. It's also going to pull the anterior portion towards the back so it can constrict it a little bit. But also, over here on this portion, it can like pull and kind of widen the walls of the pharynx. So the stylopharyngeus has a few different things it does. It can widen the pharynx. It can bring the anterior portion towards the posterior portion, or it can shorten the pharynx by lifting up. What muscle opens the eustachian tube and has absolutely nothing to do with the velum? It's the palatal tensor, or the tensor veli palatini. Okay, we also have 2 muscles that are involved in lifting the velum. That's the main things that they do. What are they? One is really obvious. It's the uvulus, right? The uvulus. And the other one is the levator veli palatini, or palatal levator. So palatal levator, it's like pulls up, it's like making it levitate. So the levator veli palatini and the uvulus are both going to lift the velum. But what about lowering the velum? I mean, one of the things that can lower the velum is gravity and just going back to its natural state. But sometimes we want to lower the velum quickly, rapidly for talking. Like when we were saying, not runt, that's going to go the other way. But let's say like, tomb. Like tomb. The word tomb. Or tome. Or tom, even. So all these, you go from something that has high pressure to something that's nasal. You want to pop the velum down quickly. We have two muscles that'll lower the velum. They're the palatopharyngeus and the glossopalatine. When is the nasopharynx open? For any nasal consonant. And some other sounds that are near nasal consonants, because remember, they're kind of like tinged with a little bit of nasality sometimes, depending on the sound near it. Okay, what about the tongue? What are the intrinsic muscles of the tongue? There are 4, and unfortunately, they're all on screen now because I didn't get rid of them. They're the superior longitudinal, the inferior longitudinal, the vertical muscle, and the transverse muscle. But what do they do? Well, the superior longitudinal is going to go, right? It's going to pull up. The inferior longitudinal is going to pull down. The vertical muscle is going to flatten. So, like that. And then the transverse muscle is going to pull together. So it's going to kind of like make it pointier and somewhat more rounded if you look straight on. So vertical and transverse. Like that. Okay, so what muscle moves the tongue forward? The genioglossus. Remember what's going on is the genioglossus is going to hook in about right here, but it hooks onto the tongue back here. So then what happens when it contracts is that it's going to get shorter. So it's going to go like that. So it hooks in at the back. You can kind of feel it like run into your teeth when you're sticking your tongue out. That's the genioglossus. That's the genioglossus that's running up against your teeth. Okay, what about pulling the back of the tongue up? Well, that's going to be the palatoglossus and styloglossus. All right, that's it for the tongue muscles. Great. Let's talk about the mandible and the face. What are the largest muscles that we have for chewing? One on each side. It's not a pair on each side. It's the temporalis muscle. What bones does the temporalis muscle connect to? It connects to a lot. I mean, first of all, it connects to the mandible, right? It has to bring the mandible up. Second, it connects to the frontal bone just a little bit, just on the very corner. You can kind of see it right here connecting on the frontal bone, just barely, right? The sphenoid bone, which is completely covered. The parietal bone, the temporal bone, which is almost completely covered. I mean, this portion is out, but the anterior portion of the temporal bone is completely covered. So mandible, frontal bone, just barely. Sphenoid, parietal, and temporal. What muscle allows you to scrunch up your mouth? And hint, it's not a sphincter. It's the orbicularis oris, which is right here. This one that looks like a weird second set of lips. So that's going to give you like all that kind of stuff. Okay, what's going to allow you to pull back the sides of the mouth? There's 2. I should have said that on there. One is the buccinator. Buccinator? I'm just going to go with buccinator. One is the buccinator, and the other is the platysma here. They're both going to pull backwards on the face. So kind of like a very strange smile. One of the other things the buccinator are going to do is keep the cheeks tight, right? Like especially if you're playing a trumpet, right? Which is what it's named after. So keeping those tight. What is going to, in addition to these two that are pulling back on the sides, I should say on this question, in addition to those, what is going to allow you to smile? There's quite a few. So go ahead and name a couple. One is not covered on this. I didn't quite cover it correctly. Well, it is the incisivus labii superioris, the levator labii superioris, which you can see here. I should have covered it, and the zygomatic major and minor. What muscles allow you to pout? There's one that is majorly involved in this and one that's somewhat possibly involved. So there's two. The mentalis is the one that's majorly involved in pouting. So you can kind of feel this if you tense up and pout. You can feel that there's tension right here. And then also possibly the orbicularis oris, because you're kind of scrunching a little bit. Like that. But mainly it's the mentalis. So if I ask you, and there's only one choice, go with the mentalis. Okay. What happens when you sniff in? This is a bad question. I shouldn't have made it so open-ended. Don't worry about answering it yourself in your head. The Bernoulli effect is going to pull these ala of the nose in. Ala means wings. So it's these portions of the nose. So you can kind of do it, right? So go ahead. I mean, like, just do it right now. I want everybody to pretend that they're in the movie Blow and just, like, sniff in as much as you can. And you can feel it. Everything moves in. Can this be counteracted? Yes. But how? Well, muscles, of course. The levator labii superioris alacui nasi is one thing that's going to allow you to flare your nostrils, and also the nasal dilators. The anterior and posterior nasal dilators. So if you just flare your nostrils, that's what's going on. You've got these here, and then the alacui nasi is pulling upwards. So all those. Now try to sniff it again. It doesn't get pulled in by the force of the Bernoulli force of you sucking in air. Okay, why is nasal breathing preferred? We already answered this question. Why am I asking it twice? It warms air, it moistens air, and it filters some junk out of the air. Thanks to your nose hairs and your mucus. When does the switch to mouth breathing happen? There's three times when we might be mouth breathing. We talked about these today. When you're talking, when you're exercising, and sometimes when you're eating. All right. So now we're going to talk about, whoops. There we go. We're going to talk about speaking. I think this is our last slide. How does co-articulation come into play with the velum position? We kind of already talked about this, actually, in this review. So sounds before or after nasals are often somewhat nasal. So if you say, the word mourns. Mourns is a really good one. Mourns. Pay attention to where the velum is when you say mourns. It doesn't pop back up when you say S, though it certainly could. If you say stop, then the velum is closed when you say the S. When you say mourns, it's open. So the S is a little bit different in either of those cases because it doesn't really matter for the S if you have the velum closed or open. You can make that sound one way or the other. And so that sound is somewhat nasal in mourns, and it's not at all nasal in the word stop. Whoops. Well, no, I guess... Oh, I just did that wrong. All right. How fast can the velum move? Well, 1/10 of a second. Just gave away the answer right there. Is velum lifting passive or active? Velum lifting. Passive or active? It's always active. Always active. Always requires muscular contraction. What about velum falling? Can be either. It's often active, depending on what we're doing, depending on the words that we're saying, but it can be either. So if we're just allowing it to relax back to where it goes because we're done talking or because we're saying things that do not require an open velum, then it can just fall on its own. But it can be active as well. How can we measure resonance and articulation? We have definitely covered one of these in this review already. Acoustics, just measuring the sound and then decomposing it. We can do it with imaging, fMRI imaging, CT scans, ultrasound, different things like that. We can also measure airflow to see, to infer velum position based on how much air is coming through the nasal opening and how much is coming through the mouth. Not mouse. What? Mouth. Oh, man. Okay, what is VPI? What does it stand for? What does it mean? And how can you tell that somebody might have it? First, it stands for velopharyngeal insufficiency. It's a lack of or weakness of, which is what I wanted to write there, lack of or weakness of the velum musculature necessary to raise the velum to a fully closed position. One way that you can tell that people have this, the most obvious way, is that they're going to have hypernasal speech, which basically just means that you're always going to hear that they have an open velum. The high pressure consonants aren't going to come out quite right. The worse the VPI, the more unintelligible their speech is going to be, and the more air through the nose you'll be able to hear. You can also feel the air coming out. You can put like a piece of glass. That sounds like you just broke a window and you put it under their nose. But you can take like a little mirror or something and you can see it fog up. And that is another clue for hypernasality. I think that if you were a really studious person, you might look up some of the surgical procedures to help VPI. I don't know why, but maybe you want to look at that. Okay, and that's the end of the review. Good luck. I don't know how to stop my video. There we go. Okay, good luck.